Okay, everybody, good morning. Can you all hear me? Yes, okay. I'm Ray Kurzrock. I chair this committee and welcome to the committee Early Therapeutics and Rare Cancers meeting. I think we have some very interesting presentations today. And we're going to start with Dr. Lara Davis from the Knight Cancer Institute. And she is leading our sarcoma working group. So we now have two working groups that are maturing from early therapeutics and rare cancers. One is sarcoma and one is CNS diseases. And I know Lara has been doing a lot of work. So please welcome, and we'd like to hear from you.
Thank you, Dr. Kurzrock. And I'm looking out there where, oh, there he is. I'm Lara Davis. Here's my clicker. So the sarcoma working group has been in existence now for a couple of years, and we are always welcoming new members. So if you have interest in sarcoma, or if you've got folks back at your home institution that are interested, just email me. I'll add you to the roster, and you'll get peppered with calendar appointments and minutes and things like that. We also have our working group meeting in person today. Folks can join virtually as well. That's in the San Francisco room, which is apparently somewhere around here, at 12:30. And I don't think we have lunch today. So you got a 15-minute window to go and grab some food before joining us. All right. One thing I wanted to start out with, and actually much of what I will talk about in our brief time is about what's going on in the NCTN overall. I have been trying to herd the cats. It's difficult, but we're at least figuring out who everybody is. And we had a good in-person meeting at ASCO, and actually got the Canadian folks and the European folks all chatting in a room together. And that was pretty exciting. And actually, the sarcoma landscape in the NCTN overall is quite busy, and there have been a number of trials that have opened recently. SWOG, of course, with multiple trials. I'm listing 3 here that are quite relevant. They all have are enrolling patients up to age at least 40. In fact, the osteosarcoma lung met study enrolls up to age 50. And so there's an opening for frontline osteosarcoma chemotherapy. So that's MAP plus or minus cabozantinib. It's currently only for newly diagnosed metastatic patients in the feasibility phase, and likely that will continue for about another 6 months or so. There is also a trial for newly diagnosed metastatic rhabdo, alveolar and embryonal. I want to please highlight the fact that there is an important surgical metastatectomy trial open through COG up to age 50. This trial is at risk of closing because it is not accruing. So please, Dr. Hofstetter from the surgical oncology or surgical committee is the SWOG champion, but please take this study back to your sarcoma colleagues and mention that this important question is never going to be answered if we don't enroll. There's my soapbox. I'm going to cover 3 open NCTN trials that I want to highlight that we should be enrolling on. I hope that these are getting opened at your institutions. First, this randomized trial in metastatic uterine leiomyosarcoma, very strong scientific rationale for the combination of olaparib temozolomide versus investigator's choice, and that can be either pazopanib or trabectedin. It is currently in the phase 2 portion. I believe about half of those 70 patients have been enrolled thus far, and it is randomized 1-to-1. if it meets parameters, it'll go into phase 3 and enroll 95 additional patients. The second alliance trial that is currently open is for advanced metastatic dedifferentiated liposarcoma. Also, good scientific rationale. It is a combination of palbociclib, which has some evidence of efficacy in this disease, plus or minus semipalumab. And it is currently in the safety lead-in with 6 patients, but will be moving on to the randomized portion any day now. I was told it should be by the end of October. So please enroll on these trials. And finally, ECOG has opened the European STRAS-2 trial. This is an important retroperitoneal sarcoma, either liposarcoma or leiomyosarcoma. This has been open in Europe for a couple of years, finally got through our system and is open and enrolling. So far, 15 sites are approved and we've got 35 pending. So make sure that your surgical colleagues are aware of this and that you're getting it open at your site. There are a few trials that I think all of them have been on this slide for a while. So opening soon is taken with a grain of salt. We are hopeful that I'll be able to say that they're actually open at the next one. All right, so for our working group, we still do not have an open trial, which is a bummer, but we are continuing to work hard towards getting that to happen. We have talked quite a bit about Dr. Wagner's trial of neoadjuvant immunotherapy in angiosarcoma. This was brought forth soon after the creation of the working group and disapproved based on needing to wait for another trial, an alliance angiosarcoma trial, to result out before resubmission. And actually those results have partially come through now and are actually quite surprising and are leading the working group to rethink this approach quite significantly. So kudos to CTEP. We've got some changes to do there, and Dr. Wagner will talk about that during our working group meeting and kind of brainstorm with all of us. There's another capsule in development with Dr. Cranmer, who is developing an abemaciclib combination with radiation for retroperitoneal liposarcoma. Of course, this would potentially compete with STRAS-2, but the timelines are a bit different. So once that phase 1B pilot is complete at the single center, then we will bring it forward for additional development within the working group. SWOG recently reached out to us to co-develop a concept in MPNST for a pilot initially. And so Dr. Livingston and Dr. Victor are working with Dr. Mead from SWOG to develop this concept. And I want to leave Dr. Jeremy Harris with plenty of time to discuss his very exciting trial that is now likely moving from a phase 2 to a phase 2/3 design after feedback from the NCI. He's going to tell us more about that in just a moment. I'm going to cede my time to him. And again, the working group meeting today is at 12:30. It is in the San Francisco room, and we will talk more about Jeremy's concept, Dr. Harris's concept, excuse me, Dr. Wagner's concept, Dr. Cranmer's concept, and then workshop a bit new ideas, including potential ideas for combo match. And with that, I will hand it over to Dr. Harris.
So thanks, Dr. Davis, very much. This is a concept that's been in the work for now a couple of years that, like mentioned, we're really excited about. I've discussed this with nearly all the groups that are in the NCTN. Upcoming next week will be the CCTG, but otherwise it's been discussed with NRG, Alliance, ECOG, ACRIN, COG. So to discuss a little bit about the background, the high risk, high grade sarcomas are at risk for local failure. And that's been well established that radiation therapy immensely mitigates that risk. The landmark study, RTOG 0630, really defines standard of care for conventional fractionation given in the neoadjuvant setting, 50 gray, 25 fractions. Now, we typically lengthen radiation courses to allow for DNA healing to occur. Some tumors, including sarcomas, have a low alpha beta ratio, which essentially means that high dose per fraction can allow for improved cell kill without necessarily needing such lengthy courses. There are two similar comparable dose schedules for sarcoma that have been experimented with in the preliminary setting. Those are 5 fraction and 15 fraction courses. Both have been tested in a single arm, single institutional setting with promising results. However, whenever we hypofractionate, we worry about toxicity, both in the acute and late setting. And there's never been a head-to-head study comparing fractionation for sarcoma. So these are some of the trials that established radiation in the conventional fractionation setting, and I highlight 0630 as the de facto standard control arm for our current study. Here are a number of the single institutional studies that have been done in the hypofractionated setting, ordered by dose. So multiple different doses and schedules have been tested. In the center, you'll see 2 studies by Kalbasi and Guadagnolo using 5 and 15 fractions. These are the favored approaches for hypofractionation, with local failure rates comparable to what we see with conventional fractionation, 5 to 7%, and toxicity comparable to what we would see, 31, 32%. As I'd mentioned, there's worry about other types of toxicity, in particular late toxicity. So symptomatically for these patients, that means fibrosis, edema, joint stiffness, wound complications, bone fracture. It's not really known the effect late toxicity may have with hypofractionation because many of the studies are initial or single institutional. We believe, as I kind of mentioned, that acute toxicities are comparable, with one exception that delayed wound healing following surgery might possibly be higher, but not really known. So we hypothesize that short course radiation results in non-inferior local failure compared to standard course. This is the treatment schema. So for pathologically confirmed resectable sarcomas, T1 to T4, any grade, they would be randomized across 3 arms. Arm A is the control arm, 50 grade 25 fractions. Arm B is the ultra hypofractionated arm, 30 grade 5 fractions. And arm C is the hypofractionated arm, 42, 75, and 15. Following radiation, surgery would occur 4 to 8 weeks later. Stratification would be by tumor size and location. Adjuvantly, chemotherapy could be considered, and a radiation boost for positive margins or gross disease would be recommended. Primary objective of the phase 2 study, after discussions with NCI, is a combination local failure, late and acute toxicity, and delayed wound healing. And the goal is to select either 5 or 15 fraction arm for continuation into a phase 3 arm. So the toxicity endpoints that I had mentioned, late-term toxicity means any grade 2 or higher, joint stiffness, fibrosis, edema, osteonecrosis, or fracture, and wound complication is typically measured 4 months after surgery and generally includes secondary operations or procedures, hospital admissions, deep wound packing, or prolonged dressing changes or wet dressing. Delayed wound healing means 6 months after surgery, the wound is not entirely healed. So following completion of the phase 2 portion, after a year of follow-up, we plan on selecting either arm B or C for continuation onto phase 3. And that will be done on the basis of failure and toxicity rates. And I'll walk through this because it'll be done in a sequential order. So the most important endpoint is local failure. So the control arm, arm A, will be compared to B as well as to C. And if inferiority is met, then that inferior arm would be dropped. If not, then toxicity differences between B and C would be compared. If either are inferior, that arm would be dropped. If not, then wound toxicity would be analyzed and then delayed wound healing. If at the end, no arm seems inferior based on statistical testing, we've set up some boundaries to establish which might have a signal of superiority, inferiority. And that again would be analyzed sequentially. So local failure with a boundary of 5%, late toxicity 5%, acute toxicity 10%, and delayed wound healing 5%. If at the end, neither arm meets superiority, inferiority, and boundaries are not exceeded, then the shorter course 5-fraction arm would continue on to phase 3. In phase 3, the primary objective is local failure with a non-inferiority boundary. Secondary objectives are local failure per protocol, local failure after central pathology review, the acute and late toxicities that I've discussed, physician-assessed functional outcome, type of surgical resection, including amputation versus limb sparing, as well as type of margin, survival outcomes, and patient-reported functional outcomes, as well as quality of life. This is the study design. So the phase 2 portion is 75 patients per arm. The phase 3 portion is 1-to-1 randomization. And again, 2-year local failure rate is the primary endpoint there, benchmarked at 11%, using a beta of 85%, a one-sided alpha of 10%. The study is powered for a non-inferiority margin of 10%, and that would require 147 patients per arm, so a total of 294 patients, including inflations. And I include as well on the bottom right some studies that are similar from the breast literature that typically use local failure as a primary endpoint and have looked at different fractionation schedules. So we draw a lot of our statistical design from those studies, which also have higher than you normally see upper bound hazard ratios for local failure. Safety analysis would be done after 30 and 60 patients to each arm, with acute wound complications being the endpoint of interest. Here's a more complete eligibility inclusion. So again, sarcoma, soft tissue sarcoma with exclusion for bone sarcoma or chemosensitive rhabdomyosarcoma. Tumor can be either a primary or locally recurrent. It needs to have had a core or incisional biopsy and not an excisional biopsy. Primary site is extremity only, with a plan for limb sparing resection. I mentioned stage of disease, T1 to 4, any grade. And with that, I think I would, are we allowed to open to questions at this point? All right, open to questions. We have a couple minutes.
Great job. I know this has been evolution for a while. This is kind of the latest version to come out of talks with CTEP directly, right? But
That's correct.
okay. So just some logistic concerns a little bit. So late toxicity, is 1 year a standard amount to look at late toxicity from radiation, or does it happen later? And can you really get an assessment after 1 year?
Yeah, so that's a great question. So following the phase 2 study, the goal is to evaluate after the final patient enrolled has follow-up for a year. It's essentially the study would be on pause for that duration of time. And so it's somewhat a logistical question of like, how long do you wait? But you're exactly right. More typically like 2 years would be chosen. And so some of the boundaries and superiority tests are narrower than you might otherwise expect to see, with that exactly in mind. And really what we're looking for is that signal.
And you address my concern is this pause that's going to happen, especially since it's a large phase 2. The phase 3 part is not that much bigger than the phase 2 part, right? 225, and you're going to accrue 225 patients, and then you're going to wait a year, and that means, like, in reality, more than a year before it starts up again, and it can be an issue a lot of times with studies and cooperative group studies that kind of pause can lead to kind of dissipation of the enthusiasm and so forth. So I think it's something we want to think carefully about to make sure we're not shooting ourselves in the foot. But but I'm glad this is coming along.
Well,
Right.
we could look at 6 months. And
But then you're late.
Right,
Right.
like that's the balance.
But I noticed in
When
the
I asked CTAP if we could keep it rolling, wow, and it was no, and it was not a negotiable. Or
I'm sorry, it was no, who said?
No,
or as the statistician at CTAP of the site of this study.
Okay.
that's right.
in the phase 3, it doesn't look like late toxicity is a major part of the endpoint. It's shifts. Like,
That's right. So also based on, that's right. Also based on kind of NCI feedback
Right.
with just really strict guidelines. What we're excited about though is allowing some of the toxicity endpoints to be analyzed as part of the primary endpoint for the phase 2 study, which initially seemed not feasible. So we're actually really happy about that portion.
A quick question. So remind me where this is.
Yeah, so it's been discussed with all the cooperative groups. I'm actually going to discuss it with CCTG next week. They are the, I think, final missing link. And then we've already had preliminary discussions with NCI, and we'll be formally submitting the capsule with narrative in the next month.
Okay, thank you.
Back briefly to executive committee.
Oh, that's right. Yes. We need more feedback because of the change in design from phase 2 to 2-3, as well as those other discussions. Yeah.
Yeah, there is a comment, radiation oncology at our site would support it, but did express concern for the toxicity risk. This is from Adrian Victor.
Yeah, sorry.
Okay, well, thank you for that presentation and making headway with this important question. And let's move on to the next topic, which is Dr. Chen, who Dr. Chen is an associate professor at University of Washington, Fred Hutchinson, and is going to talk about his randomized phase 2-3 trial. Thank you for coming.
Yeah, thank you. Thank you for having me. So pleased today to give a quick update on SWOG S2012. This is a randomized phase 2-3 trial of first-line platinum etoposide with or without atezolizumab for advanced metastatic poorly differentiated neuroendocrine carcinoma. So always a lot to say. So with that, we'll start with just a quick background about neuroendocrine neoplasms. So just to remind you all, these are cancers that come from neuroendocrine cells. So as I kind of explained it to patients, neuroendocrine cells are hormone-producing cells. And so literally these types of cancers can occur anywhere in the body. But most common clinically, we often see them in the GI tract or in the lung. And there are some cases of unknown primary. Now, one of the things that we've come a long way is that we've used a lot of different terminology. So you might hear carcinoid tumors, neuroendocrine cancers, neuroendocrine carcinomas. And I think one of the biggest advancements has been from the pathological characterization. And so this is the 2019 WHO classification, mainly for GI neuroendocrine neoplasms. And we group neuroendocrine neoplasms based on 2 factors. So one is their differentiation status, whether they're well-differentiated neuroendocrine tumors or NETs, or poorly differentiated neuroendocrine carcinomas or NECs. And we'll be focusing mainly from the NEC standpoint here. But the reason this is important is, in neuroendocrine carcinomas, we have 2 types of histology. So either small cell or large cell, basically based on the shape of the cells. But the reason this terminology came about is if you notice in the well-differentiated neuroendocrine category, there's another group of patients who have fast growth rates, Ki-67 of greater than 20%, which we call well-differentiated grade 3s. And the reason we make this distinction now is that in the past, we used to lump the grade 3s, anybody who had a fast growth rate, into neuroendocrine carcinomas. But what we've learned now clinically is that this is a very different entity. So I show a study on the left here looking at survival curves. On the black line at the top are your well-differentiated grade 1 and grade 2s. These are your neuroendocrine tumor patients who live for many years or decades, compared to your neuroendocrine carcinoma patients in red, which we'll discuss, who have a very poor prognosis of a year or less. But the well-differentiated grade 3s, the blue line in the middle, actually have an intermediary prognosis. We're also starting to learn that group of patients actually don't respond to traditional chemotherapy like platinum etoposide, and they actually respond probably better to our neuroendocrine tumor treatments. And so it's very important as we think about trials and neuroendocrine cancers that we make sure that we're having a very homogeneous patient population. So when we think about neuroendocrine carcinomas, what's the prevalence? I mean, this is a rare cancer, and obviously it's being run through the Rare Cancer Committee. But here was a SEER database analysis of neuroendocrine carcinomas in general. In panel A on the left, that is looking at disease site. The vast majority of neuroendocrine carcinomas occur in the lung. So that's what we term small cell lung cancer or large cell neuroendocrine carcinoma. If we think about extrapulmonary, so everything outside of the lung, which is a small piece of that pie, break it down, a third of them are GI, but then other thirds are breaking down into other disease sites, particularly GU and also the gynecological tract. On the bottom left represents the different histologies. So I mentioned neuroendocrine carcinoma, you have small cell and large cell histology. The orange represents small, the blue represents large. And what you can see is that for most disease sites, small cell tends to be the predominant histology, but in GI, we actually see a little bit more disproportion where we actually see more large cell compared to small cell. So when we think about what is our current standard treatment paradigm, so we've actually just extrapolated management from extensive stage small cell lung cancer using combination platinum etoposide, platinum being either cisplatin or carboplatin. And for the longest time, we actually based all of this on large case series or retrospective studies. We finally had one prospective study that has now been published in JAMA Oncology, I believe. And basically, no matter what study that you look at, patients have very poor outcomes with platinum etoposide. So protecting about a year or less. And so there definitely is a high unmet need to improve outcomes for these group of patients. Now, naturally, when we think about lung cancer, we also think about immunotherapy. And so what is the data in terms of the use of immunotherapy in both small cell lung cancer and extrapulmonary neuroendocrine carcinoma? So if we look at the data in extensive stage small cell lung cancer, single agent checkpoint inhibitor, no matter which one that you use, have very low response rates. So often in the single digits with very, very low still overall survival and progression-free survival. And likewise, in the very limited data set that we have for extrapulmonary neuroendocrine carcinomas, single agent checkpoint inhibitor also doesn't provide a whole lot of benefit. So the long story short is that using single agent immunotherapy is not going to move the bar in this disease. Now, what about combination treatments? So I think this group obviously has a lot of experience in running the DART study, SWOG-1609, which was evaluating nivolumab and ipilimumab in rare cancers. And one of the rare cancers they studied was the neuroendocrine cancer cohort. And one of the first things that we learned from this trial is that combination therapy seemed to work, but it mainly worked in the higher grade neuroendocrine cancers, not the lower grade neuroendocrine tumors. And likewise, this data now has been recapitulated. So in France, there was the NIPI-NEC trial. This was not a head-to-head trial, but they were looking at nivolumab alone versus nivolumab and ipilimumab. And the response rates in PFS and OS are still fairly similar to what we've seen in the DART study. Last week, we had our North American Neuroendocrine Tumor Society meeting in Montreal. They also presented some data on durvalumab and tremelimumab. So similarly, we're seeing some activity in the refractory setting, but again, in the setting of combination treatments. So with all of that, understanding that maybe there's a role of combination treatments in a refractory setting, what if we move it into earlier line disease setting? So we know in small cell lung cancer, there are several studies looking at chemoimmunotherapy, and one of the studies here is the Empower 133, which looked at extensive stage small cell lung cancer, randomizing patients to carboplatin etoposide with atezolizumab induction for several cycles, and then if you don't progress, you get maintenance atezolizumab versus the standard of care, which is just 4 cycles of platinum etoposide induction, and then you monitor patients for progression. And with that, there was definitely a survival benefit, although very modest. If you look at the median survival, just a 2-month absolute benefit in survival. However, if you look at the longer term outcomes, particularly looking out at 12-month overall survival, there was a greater degree of patients who benefited from the chemoimmunotherapy approach. And so because of that, this led to the FDA approval of atezolizumab in March of 2019. So naturally, that got us thinking, well, what about using immunotherapy in extrapulmonary neuroendocrine carcinomas? Some people are doing this off-label, but without any data. And I would challenge people to think about, is extrapulmonary neuroendocrine carcinoma the same disease as small cell lung cancer? And I don't think it is. So when we think about small cell lung cancer, that's a cancer that often occurs in the context of smoking, which develops mutations, and then oftentimes that might confer benefit to immunotherapy. But here, most of our extrapulmonary neuroendocrine carcinoma patients are often healthy patients. They get this out of the blue. And so we don't know if immunotherapy is going to be as helpful. We also know that extrapulmonary neuroendocrine carcinomas is a very heterogeneous disease. And what I mean by that is in GI, this often occurs de novo. So if somebody walks in, they get diagnosed with a neuroendocrine carcinoma. In prostate, for example, prostate small cell, it often starts as a prostate cancer. You treat them with hormonal therapy, and as a resistance mechanism, they develop prostate small cell. So that underlying prostate adenocarcinoma, does that also affect the response to treatment as well too? So there's a lot of different questions that need to be answered. This is a study outlining the mutational profiles of various different disease sites. And the take home point is, while there's some mutations that are similar, like TP53 and retinoblastoma, there's many mutations that are actually very, very different. So we need to really kind of study this disease in more detail. So with that, that led to the development of SWOG S2012. So this is a randomized phase 2/3 trial. And I'll say that since conception of this trial, when this was early designed, this is very different from what I had imagined, but I think also with the input from the NCI. So this is for all extrapulmonary neuroendocrine carcinoma. So no matter, and it could be anything outside of the lung, even unknown primary. And we're trying to be broad here. So patients don't need to necessarily have RECIST measurable disease. They just need to have evaluable disease. Being some patients, let's say, have peritoneal disease or pleural effusions, those patients would still be included in this trial. ECOG performance status is 0 to 2, and understanding that some of these patients have to start therapy early. We do allow up to 1 cycle of standard platinum etoposide prior to enrollment, just not other chemotherapy regimens. And we are allowing patients with also asymptomatic brain metastasis as well. So trying to make this as a real world study as much as possible. And what you'll see here is the arms that we're investigating. 2 of the arms are basically similar to Empower 133. The orange arm is the induction of 4 cycles of atezolizumab and platinum etoposide, followed then by maintenance atezolizumab. The blue or grayish on the bottom is platinum etoposide alone, followed by observation. There's a red arm, though, that's not included from prior studies, and this is just induction chemoimmunotherapy alone, followed then by observation. And the reason being is that the NCI stated that all of the small cell lung cancer trials to date have just included a maintenance immunotherapy arm without really any great data. And I've already shown you the data, the single agent immunotherapy doesn't provide a lot of benefit. So this is a way to basically understand better what is that contribution of the maintenance arm. And we do have a statistical analysis set up such that if that middle arm shows to be inferior, that arm will close early to accrual. So it won't just keep enrolling if we don't see a lot of benefit. So the primary endpoint here is overall survival, and secondary endpoints being OS, PFS, response rate, and duration of response. And for translational analysis, this is an exciting part for us as well too. We are banking all tissue and blood, and we'll be collaborating with colleagues, Dr. Carlos Gay and Lauren Byers at MD Anderson, where we'll be looking at particularly relevant biomarkers and specifically looking at these 4 transcription factors that in small cell lung cancer might actually predict response to chemotherapy or immunotherapy. And we'll also be looking at ctDNA and how that correlates with response as well too. Now, When the study was originally designed and it was activated in December 2021, the NCI asked us to restrict it to small cell only, wanting a very homogeneous population. However, being a very rare cancer, we made it even rarer if we were restricting the small cell only. Part of the reason they did that at the time was that we had another trial that was a neuroendocrine trial, but did not enroll small cell patients. They enrolled large cell. So they were also worried about the competition. Long story short is after that other NCTN trial closed, it allowed us to revise this trial. And so we had a protocol amendment that was approved January of this year to allow all neuroendocrine carcinoma subtypes. So basically large cell, small cell, and even if you can't really tell large cell or small cell, as long as the Ki-67 is 55% or greater, patients will be eligible for this trial. And I would say that has really been helpful for this trial. So originally, when we restricted the small cell, we had 3 patients in 1 year of enrollment. And now we are up to 24 patients in just this year. So we are now averaging of about 3 patients per month. So I'm very happy to see that. We also made some small little things in terms of imaging frequency and such, because some of the sites had commented that there were some insurance barriers and how frequently scans could be done. And so we made some small changes, and we are going through another protocol amendment to revise some language and make some more clarifications. So as I mentioned, this slide is outdated as I had to hand it in. So we had 1 more patient in the past couple of weeks. So now it's 24 of Plan 189. I know I have a couple of patients at my site that I'm also trying to enroll. And so we are trying our best. And I would say if you don't have the study open at your site, I would strongly encourage you to open it. And we are trying to promote this with other groups. Last week at our North American Neuroendocrine Tumor Society, I met with members of the NCTN as well too, both from ECOG, Alliance and such. And I think everybody's still very much in favor of the study. But again, it's a rare disease. Understand it's hard sometimes to accrue, but we're just trying to keep interest because this is a very, very important trial. We don't have any prospective data about chemoimmunotherapy, and we really, in order to help move the bar for this disease, we really need to accrue onto these trials, answer the questions so that we can develop the next generation of trials. So with that, I will end there.
Thank you for that presentation. I see that Chris has some questions and I have some questions too. So I will let Chris, I'll be a gentleman and let Chris go first.
I don't know how to respond to that. But I will go first. Just real quick, David, excellent presentation. You showed the nice pie chart with a breakdown by different organ sites.
Yeah.
Do you have an idea our accrual? Are we accruing to GU and GYN?
Yeah.
And if not, I know we have liaisons, and
Yep.
if we're not, is there a way to kind of boost the word with?
Yeah, absolutely. So I think first question in terms of the breakdown of the patients, we've had actually quite a few patients where they have not been able to delineate small cell versus large cell. It's just a neuroendocrine carcinoma. So I would say that's the vast majority. After that, it's a small smattering of the histologies. In terms of how this study is being run, yes, we do have SWOG disease liaison. So we have Earl Burgess, who's our GU disease liaison. We have Elizabeth Swisher, who's our GYN disease liaison. And then we also have champions within ECOG, Alliance, and also NRG. So they're all been working to promote the study. One of the things I know we don't do a lot for our SWOG studies is having monthly calls. So I did meet with the SWOG Recruitment and Retention Committee. So we've been talking about having those kind of monthly meetings. So we just keep the momentum on the trial, keep advertising the trial. I know Dr. Blanke did a very nice job of highlighting this trial in one of the SWOG newsletters. So I think we're trying to work on this to keep it promoting. So.
Okay, a few of my questions. How many sites does it open at?
So if I recall, we're at about close to 100 sites, and there's still like another 130 that are still in activation. So one of the things is a lot of the academic sites, just like at our site, there's a huge queue of NCI trials. So now some of the sites are just finally getting this study activated.
Okay,
So.
and the second thing is I'm glad with the amendment that the accrual is speeding up. but it needs to be even faster. So that really unfortunately falls on your shoulders to, reach out to your colleagues across the country. You might reach out to Alex Fan at MCW. I don't think we have it open,
Okay.
but she's running a neuroendocrine clinic.
Okay.
And if she's interested in opening it, I think that would be great.
That's good to know. Thank you.
And then I had a question about neuroendocrine in general, just so well-differentiated grade 3. What is the Ki-67 on those usually?
Yeah, usually we see them more in the 20 to 55% range.
So they
the
do have a
lower range.
high Ki-67.
Yeah, they do have a high, but not as high as neuroendocrine carcinomas, which are usually more like 80 to 90%. So. Yeah.
Okay, those are my questions. Dr. Young Chai, do you want to?
Yeah, I just have a quick question. So we do see a lot of therapy related, whether it's immediately after failure of prior therapy, which could be, hormone targeted, it could be anything. So how do you deal with those, like, prostate, salivary gland, breast? They could have small cell extrapulmonaries.
Yeah. So this is where we had a lot of input from our GU colleagues. So basically their management is they'll still manage the hormonal component with the traditional hormonal therapies, but once the small cell or neuroendocrine carcinoma component pops up, they'll add on chemotherapy on top of that. And so how this study is written is such that we allow the investigators to continue whatever hormonal therapy they feel is best. So we're not controlling any of that. We're just kind of mainly overseeing the neuroendocrine carcinoma treatment part of it. So.
Got it. That's great.
Other questions? Okay, thank you for
Thank
that nice presentation. So our next speaker is Dr. Young Chai, who serves as vice chair of our committee and is one of the co-PIs on DART. And he is going to talk about DART in general, and especially his focus has been on the translational aspects. And I think he's also talking at one of our plenaries today. So please go and hear him.
Thank you. Thank you for inviting me to talk about the DART, our precious baby of this committee. So
Can everybody hear him?
can you hear me okay?
Yeah.
Okay, thank you. And we have my slide. We'll start with ETRC. Yep. Okay. Okay, these are my disclosures. So I'll do a brief update on the clinical trial side, since Dr. Patel couldn't be here in person. And then I'll talk about the recent evidence behind the translational medicine component of the DART trial. And then we'll talk about the collaboration that we have with CMAC and the commercial laboratories. So the whole idea is we've seen a great success story of combinatorial immunotherapy targeting PD-1 CTLA-4 in renal, melanoma, anal cell, Merkel cell, you name it. And we want to replicate the success story in rare tumors. Since when we started this trial, we really didn't know what the response rate would be. And we thought if we pull them together in a mixed cohort, that we would do a signal finding study. So this is a study with primary objective of being overall response rate, and we have had Simon two-stage design put in, but this was a very popular study. I don't think most arms over-exceeded we accrued more than 16 patients. So we used the Nivo-Ipi Checkmate 227 regimen, which is the Ipi 1 mg per kg given every 6 weeks. And then Nivo fixed dose 240 milligrams IV every 2 weeks until progression or unacceptable toxicity. So here is our first design of the study. So we were first told by NCI to leverage or use the NCI matching platform. So they could only go into match when they screen fail or they get into match and get progression on the agent, and then they have no other matching therapy from a subsequent NGS screening. And it happens to be that the people who are coming to NCI match trial, 1/4 of the patients were rare tumor patients. So they would fit right into our study. So we had this trial open for a little more than 6 years, and we accrued total of 798, just closed this spring. And we had more than 1,000 study locations across the United States. So here are some of the select cohorts with responses. As you can see, the response rates really range from 5% even up to 44%, as in the case of high-grade neuroendocrine tumor. And you can see sarcomatoid lung, angiosarcoma, metaplastic breast, thyroid, small bowel, ovarian granulosa cell tumor, and vulvar cancer, desmoid. So I think there's no one theme running through this, that you would what was traditionally thought of as cold tumors did show responses. And what's very interesting is a lot of those cases that had response were long-lasting responses, more than a couple of years. As you can see in high-grade neuroendocrine, one of the patient here had neuroendocrine tumor of esophagus, and she still remains disease-free in my clinic after 3-4 years on therapy. She's no longer on therapy, but a lot of patients, CR, PR, very durable responses. And this, the first graph is the one from the total combined neuroendocrine tumor with low and high grade, and below is the high grade dedicated cohort. And based on these evidences generated, NCCN has adopted this into their guidelines, as you can see here, for the high-grade neuroendocrine, as well as the extrapulmonary small cell lung cancer. And the angiosarcoma data is here. You can see some of deep responses, and this also led to incorporation of nivo/ipi as one of the regimens for angiosarcoma as well. And here are some gyne cohorts that we had. We saw very nice response across different histologies, such as vulvar, clear cell, granulosa cell, and a very, very rare tumor, such as hypercalcemic type small cell ovarian cancer. And the one patient had CR that is still ongoing. And we also have metaplastic breast cancer from our collaboration with ECOG group, Dr. Sylvia Adams. And here is the metaplastic breast data. And 3 of the patients are still having ongoing durable responses. And you have the thyroid cancer data, which these are not, one patient was anaplastic with PR, but most of them are well differentiated, which is also previously thought of as cold tumor. So I think unless we treat, really don't know. And we are now doing the translational piece to it. So we're learning why they're having response, why they're not having response. We have bronchoalveolar cancer, salivary gland tumor. These are the non-adenoid cystic, and you still see a fair number of PRs with good durability here. So first of all, with the translational medicine, we want to know their genomic and immune landscape of rare tumors, and then correlate these responses seen in rare tumors with the biomarkers that we know of: genomic, transcriptomic, proteomic, or immunologic biomarkers. And also, now we're trying to explore what are the predictors of immune-related toxicities with the combinatory immunotherapy as well. So we're going to go into 4 different layers. So this is to show that first, because we use the NCI Match platform, we do have access to their NGS and some of the FISH IHC biomarker data. And this is their NCI Match CLIA Lab network. And first, we are interested in the DNA damage response gene aberrations, as well as the tumor mutational burden. Here is the pan-tumor data, which nicely correlated tumor mutational burden with the overall response rate across different tumor types in different clinical trial setting. Here is also TMB predicting overall survival after immunotherapy across different cancer types, pooling different immunotherapy trials in a single institution. This is also data showing that the nivolumab frontline in non-small cell lung cancer in metastatic setting showed that there was a progression-free survival benefit, but never panned out to overall survival benefit. So to me, this led to not meeting the primary endpoint of the study, and this talks to the need of a second agent that can provide more durability and overall survival benefit. This is also another frontline trial that did not pan out, a atezolizumab single agent study. As you can see, it did correlate very nicely with the blood TMB level and the response level. However, it did not show any correlation with the overall survival. What did correlate very tightly was the serum CRP level, which can represent the host immune inflammation level. This is also atezolizumab frontline in urothelial carcinoma, atezolizumab versus chemotherapy in another urothelial trial, and which shows unlike lung cancer, that there seems to be overall survival benefit correlating with TMB in this setting. So, which alludes to the fact that it might be histology specific. And this is frontline nivo-ipi trial. There's no randomization, but this looked at TMB and PD-1 level, and there seems to be independent relationship between the two. Both had independently predicted PFS and benefit, as well as overall objective response benefit. Here is the lung cancer data that showed nivo-ipi in lung cancer with high tumor mutational burden. And here, if you only look at the group with high TMB, then PD-L1 plays a role predicting better overall survival. And whether you have a high tumor mutation burden, or low tumor mutation burden, there is benefit of doing the combinatorial nivo-ipi versus chemotherapy. And this benefit is pronounced more in PD-L1 negative patients. And this is a subgroup analysis that just confirms that finding. So the TMB across different tumor type has been FDA approved in June, early 2020, as a pan-tumor marker, and it could be any FDA-approved NGS that can calculate TMB, and their cutoff at that time was 10 or greater mutations per mega base pair. And this was solely based on the non-randomized Keynote 158 as a very innovative pan-tumor indication at that time. And at their objective response rate for approval was 29% with nice duration of response. This is the Keynote 158 that show you can see the different type of tumors that were enrolled there. And interestingly, even in small cell lung cancer, cervical cancers, there were high level of TMB high group patients there. But what's noticeable, they didn't enroll like a lot of different histologies. They were able to just enroll less than 10 patients and still get the pan-tumor indication. So this is their response rate and survival you can see there. And what we learned from this trial is that objective response rate was not different across PD-L1 high versus low group. So again, the theme is that TMB and PD-L1 and going forward, genomic traits such as immune hot or cold tumors, those were all treated as independent variables. They were orthogonal of each other. So this is a small cell lung cancer data where you do see that TMB does predict overall survival benefit, but PD-L1 does not. And this is a recent article that talks about the high tumor mutational burden fails to predict immune checkpoint blockade across all cancer sites. So the emphasis in all cancer sites. So they looked at different cancer types and they were able to classify cancer types as category 1 and 2. So category 1, there seems to be a tight relationship between TMB and immune cell infiltration, versus category 2, there isn't any. So the clinical trials have shown benefit of TMB being used as a predictive biomarker in only category 1 type tumors, and they do show individual tumor type data that supports that hypothesis. So, and then what do you see when you add chemotherapy? Then the predictive role of TMB is not there anymore. So that's shown based on the keynote 021 and 189. As you can see, TMB does not differentiate overall survival benefit or objective response benefit. Now we go into different genomic traits such as JAK1/2 or beta microglobulin gene mutation, or even the HLA class loss of heterozygosity. And they all have been linked with differential benefit to immunotherapy. And the JAK and STING pathway serves as the downstream pathway of immune activation. So it doesn't really matter if you have TMB high or PD-L1 high, the downstream or the bottleneck is blocked, so you won't see any responses. And there are evidences of chromatin remodeling gene, loss of function mutations affecting the immunotherapy responses. And then the hypothesis is that they would affect the neoantigen recognition process by and having frame shift is a mutation is the one that greatly affects that process, producing differential effect of immunotherapy as well, which this is the data that I've shown from my clinic at Northwestern here. And then this is the correlation between the frame shift in DEL landscape with the tumor mutational burden. And this is also looking at PD-L1 gene amplification, which is present across 0.7% across different tumor types. Dr. Kurdrock and her group has shown this, and based on this data, we did add a separate cohort into the DART trial, and this group has accrued a few patients because there was a confusion whether amplification means IHC amplification or copy number amplification from the individual site, although we sent them a lot of education materials. The last thing is from the genomic trait is the germline. Yes, we do check for germline, and we are trying to see if any of those traits relates to differential benefit from immunotherapy. And MMR deficiency will be checked as well. This is the current FDA indication that led to pan-tumor indication of use of pembrolizumab or dostarlimab in this population. Here is the transcriptomic data. They've been looking at different gene expression markers. Melanoma group have published the IPRES marker. There's been Wnt beta-catenin pathway markers, chemokine gene signatures, and then HLA's transcriptional loss as another predictor of resistance to combination immunotherapy. And in clinical trial world, gene expression profile has been used as a companion diagnostic, and this is where in this TISO Empower 150 trial that it was used to differentiate group into T effector high group and low group. And this is how that two groups have shown differential expression response to different therapies in immunotherapy world. So I will skip. So, and then this is the TIL, tumor infiltrating lymphocytes, as well as other immune cells that have shown differential activation in non-small cell lung cancer. Let me see. This is the H&E slide based the AI analysis of the TILs, and by measuring the TILs, you can show that the non-small cell lung cancer patient who received immunotherapy has a differential PFS and OS outcome independent of the PD-1 biomarker. And this is also using the AI-powered H&E analysis of tertiary lymphoid structure, and just having the TLS versus not having the TLS nicely separated the PFS and OS curve of the non-small cell lung cancer patient who received immunotherapy as a frontline. And then of course, we did the PD-L1 IHC, and we also had the commercial laboratory that is running the mass spec MALDI-based proteomic signature. And this is the NIVO-AP data produced in melanoma group. And we're hoping to see similar trend in our group as well. So and then we're looking at host serum proteins as well as the phenomics. We're not looking at microbiome for now. We looked at neutrophils in our group, and whether it's chemo or immunotherapy, we know it does have prognostic effect. So we're trying to see if that is replicated in our group as well. And then the effect of the neutrophil and TMB are also independent of each other. So the bottleneck can be there, and this is a nice study that shows that T cell infiltration, gene expression profile, PD-L1, as well as the TMB are all independent of each other. And we're hoping to do a pan-tumor analysis to see if this trend is there in our dark cohort as well. So I will go fast. So we want to look at immune toxicity as an endpoint, and here's a nice analysis that showed that even a four-year update data on this immunotherapy trial, patient who discontinued treatment because of the immune side effect were the ones who actually had the longest overall survival benefit compared to the ones who did not develop side effects. And this is using the serum proteomics, proof of concept that this platform may be able to predict a better response as well as the shorter time to toxicity. And I will pass on. So we do have, I talked about the industry collaboration with the proteomics and the ctDNA, and we have collaboration with CMAC. I know Dr. Haymaker will talk more about the collaboration and the recent data. So I will skip through our collaborations here. So where we are now is we have explored the neuroendocrine cohorts, 3 cohorts. And then we have explored the thyroid cohort, and we do have the metaplastic cohort, as well as the angiosarcoma cohort that will be exploring the in-depth biomarker landscape. And then here is the thyroid cohort update. We just finished writing the manuscript. We did not see any correlation with the PD-L1 expression, nor the TMB separated the survival. And we've done the transcriptomic analysis that did not also show any meaningful correlation with patient outcome. But interestingly found that the PD-1, PD-L1 double positive TILs were correlating with survival. So that was the most recent update from the TM. We have submitted our proposal for the second CMAC grant that will explore not only the high responder groups, but also the whole rare cancer patient samples, which are really precious. And we want to build rare cancer TCGA platform based on our DART trial. And we're hoping to combine all these radiomics, pathomics, phenomics, and the genomics, transcriptomics, all of these biomarkers that we will be able to find from these pan-tumor trial and be able to add those layer into AI-based modeling to better predict or better personalize patient treatment selection for this dual immunotherapy. I just want to bring your attention that our statistician Megan did, and she presented this at the ASCO, and I think this was brilliant. And just a simple change in tumor size by traditional RECIST perfectly correlated with the 1 year overall survival, as you can see on the graph on the left side, and the 1 year survival on the y-axis, and the change of the tumor size. And there is no inflection point here. So the really nice linear curve, it tells us that the initial response is really important to predict patient survival in this high unmet need population. So just ending statements for my talk. Yes, we can accrue to this trial. We've completed accrual over 6 years. We accrued 798 patients across 1,000 community locations, and more than half of them were community sites. And in fact, we are prepping for DART2 because we do believe this rare tumor population is precious, and it's best that we tackle this as a group rather than individual trials. And we are learning from the multi-omics TM effort from the DART tissue and blood samples that are already stored in our SWOG repository. And the CMAC, CIDC, the SWOG, the team science effort is ongoing. It's in action, and we're very extremely happy that this is a collaboration that is producing results, and hopefully will change suboptimal practice in this field of rare tumor. And that will, and all of this effort will lead to personalization of the combination immunotherapy in rare cancer field. And I do believe the AI will have a role once we analyze all these data and have developed biomarkers. So with that, I will end my talk. Thank you.
Thank you for that very interesting talk. Does anybody have any questions? You want to try the other microphone?
What was the rationale for continuing EP indefinitely? Because usually it's very effective if you just give for 3 to 4 cycles. And there are trials where we give only 1 cycle. And the second comment is that, as you pointed out, if you discontinue immunotherapy, that cohort did better, which also supports partly to the first question that you don't need to treat these patients for such a long time.
That's a great question. We actually asked that same question when we were writing the protocol. And I believe TREMI is taking that approach, that the Poseidon trial that led to TREMI approval in non-small cell lung cancer just did TREMI for 5 cycles. And I know melanoma did just 4 cycles with the Nivo-EP regimen. So we did ask that question to BMS, whether we can stop EP in the middle. And it was the BMS policy that lung cancer, they were doing the Checkmate 227, which is 1 mix every 6 weeks, and they did believe that the toxicity was pretty tolerable if you do that way versus 3 mg per kg every 4 weeks. So with that toxicity data and then their favorable data coming out from lung cancer Checkmate 227, BMS insisted that we keep that continuous EP dosing for this trial.
So it's a much lower dose.
Yes.
And spread out over a longer period of time, but it goes on and on.
Right.
But I don't think the response, time to progression or survival is dependent on the dose in immunotherapy. This was the belief when we started treating melanoma patients initially. That's why the dose was continuously decreased. I'm not sure, as I said about the duration, even the dose, we don't know the correct dose.
Yeah, you're right. We don't know. We don't have the randomized trial to compare high or low. I guess outside melanoma and even melanoma, I don't think there is a strong rationale to advocate for one way or the other. So yeah, good point. Thank you.
I just had a couple of points that I wanted to really briefly make, and then I have a question, and then we need to move on. So the trial now, we basically published 4 or 5 cohorts, and one's impressed just stational trophoblastic tumors, and it's pretty gratifying because 2 of them have already changed NCCN guidelines, and I think the other 2 will also change NCCN guidelines. So I think it's been a really important contribution to the rare cancer community. The other thing is, Dr. Chai and I always agree on this, so I have to say it, disagree on this, is on the role of TMB. I think the TMB cutoff of 10 is a weak cutoff, and that dilutes the strength of TMB. And we actually published a paper in Cancer Discovery that showed that between TMBs of 10 and 16, there was almost negligible response rates, something like 2 to 3%. But when you started getting across over 16, then you start to get real responses, and really across tumors. So I'm not saying that every tumor is the same, but I do think that our data supports TMB and being an important pan-tumor marker. Dr. Chai, I will just say, doesn't agree with that. So we always discuss that, but I had to get it in there. And then one question, how many tissues and blood samples do we have stored? Do you know?
So, yeah, it's heartbreaking to see so many. If we don't have the responder samples, it is heartbreaking. But I would say probably about half. A lot of missing, tissue and even blood. And the blood came about 1/3, about halfway, because we amended the protocol. It came on board amendment number 3. And even though we mandated 3 time points, and we don't really have 3 time points. Yes, so the study coordinators, have to do a better job.
Okay, thank you so much. You've put a tremendous amount of work into it. And on that vein, Dr. Kara Haymaker, who has been doing is at MD Anderson doing the critical translational work on this. And we're running 4 minutes behind, and I'm going to cede my 4 minutes to you, so you can don't have to be in a hurry. I didn't have much to say at the end anyway.
Okay.
So
No worries, and I can be quick. Thank you all for the opportunity to come and present on the collaborative effort between CMAC and DART cohorts that I'm going to talk about today. We've had such a wonderful collaborative effort with SWOG, and we're happy to share what we're doing. So I have no conflicts related to the study or presentation. And this is just to highlight the amazing teamwork. This is not everyone that has been involved, but really highlighting the match collaborators, our NCI collaborators, our DART leaders, as well as the 3 different CMACs and the CIDC that are all participating and working together on this study. Today, I'm going to talk about the translational updates from cohort 23 and 52. I know you all don't need to really be reminded, but just as a quick note, cohort 23 was the non-pancreatic neuroendocrine cohort that really showed that response was found in high-grade tumors, and therefore the new cohort, cohort 52, was added to expand upon that by focusing on high-grade neuroendocrine carcinomas. And so what we've done in collaboration with SWOG through the DART study is really trying to understand why these patients respond or don't respond to this combination strategy, utilizing both tissue that's collected at baseline only, as well as the longitudinal blood that's collected at baseline and cycle 2, week 9, and trying to understand what are these baseline mechanisms within the tumor that could help us to rationalize why patients do better or worse, thinking about transcriptomics, genomics, the cellular component, and also how those cells are interacting with each other. And we'll take some more time to really focus on that aspect specifically. And then also thinking about the TCR repertoire. Are we actually engaging in an immune priming event, especially because of the role of ipilimumab in promoting immunologic priming, and then with Nivo really helping to release those cells that are already present. And then also looking longitudinally in circulation to see how the cytokines, chemokines, immune activation states, as well as that potential for priming is happening. So in terms of the data available for analysis, you can see that shown here across all of the samples. We have, I think, 15 patients overall where we have all data points, and we have a total of 43 tumor patients that we were able to analyze that passed QC, and a total of 46 patients because we had a few that didn't have tumors past QC, but did have blood with samples available for analysis. This is just showing from the cases that we were able to analyze in this combination strategy, the overall survival and progression-free survival curves. Now, when we look at the baseline tumor, we really wanted to ask the question of whether or not we could identify any type of exploratory biomarkers that could correlate with response. And so we started looking first at those that Dr. Chai really described so nicely in terms of PD-L1 and TMB. Now, in cohort 23 and 52, we had very, very, very few cases that had any appreciable PD-L1 expression by chromogenic IHC, and we did not see any association with either overall survival or progression-free survival, and you can see that in C and D here on this slide. This is very fresh data, but we also looked at whether or not TMB happened to correlate with outcome. We have a median TMB of 16.5. The red arrows here are indicating patients that had a PR or a CR, and you can see that we had responses across the broad range of TMB that we could see. We also didn't see any association with any type of microsatellite instability signatures. So what did we find actually? If PD-L1 didn't correlate, TMB didn't correlate. What was very interesting when we looked at the transcriptomic data is we saw that B cells within the tumor microenvironment were extremely important. Patients that had predicted B cell scores either had a CR, PR, or a stable disease of greater than 6 months. And you can see here in B as well that this really correlated with time to progression. We also saw that patients that had more antigen presentation machinery, the presence of a tertiary lymphoid structure signature, and also the presence of predicted myeloid dendritic cells within the microenvironment also did better on therapy, and they either were falling into PR, CR, or a stable disease of greater than 6 months. You can see the TLS gene signature there at the bottom left that we were using to make this assessment. So we then wanted to see if we could actually identify, because just predicting their presence with a genomic or a transcriptomic score is great, but we have a very strong pathology component, and we really wanted to understand if we could actually see these structures. Can we identify lymphoid aggregates or actual tertiary lymphoid structures and plasma cells in the microenvironment? And so what we did here, this is work that was done by Caddy and Louisa and Gayatri on the team, looking actually at the H&Es and identifying plasma cells as well as relationships of lymphoid aggregates to tumor cells. We did not identify any mature tertiary lymphoid structures, but we did identify plenty of lymphoid aggregates that we define as being clusters of lymphoid cells that are 50 or greater, and they are lacking a germinal center, therefore they are immature and not mature TLS. Now, when we then looked at the presence of lymphoid aggregates in relationship to B cells as well as to outcome, we saw that patients that responded to therapy did have a higher B cell score, as we'd already talked about, and also had higher lymphoid aggregate presence. But we did have some patients that did not respond to therapy that also had lymphoid aggregates that we could identify at baseline. So just the lymphoid aggregate itself did not stratify by responders versus non-responders. And interestingly, we also saw an association of plasma cells. So that side of the adaptive immune system is not as well understood and is a really interesting focus right now in the field in terms of thinking about how plasma cells can be actually helping to promote the anti-tumor immune response. And we can see them very clearly in these cases. So then we wanted to ask the question, well, maybe it's just, these are very immunologically cold tumors, but maybe it's actually that if we have more immune cells present at baseline, those patients actually do better. And so we turned back to our multiplex immunofluorescence data and just looked to see where the cell types that we could assess were present. And we can find them both within the stromal compartment, as well as actually within the tumor compartment, within the tumor microenvironment. And we can see memory cells, we can see different types of T cells, and we can see PD-1 positive TIL that are present both in the tumor and in the stroma. But what we found, surprisingly, is that immune infiltration does not cluster by grade. We really thought that this was going to be a feature because we see responses that are restricted to our high-grade lesions, but we don't see any association with grade. We also didn't see any differential immune infiltration just by counting the cells by response. What you can see here in the blue square is that we can see responses in immune included high-grade tumors. We had 3 responders, and we also had a number of non-responders that had similar levels of infiltration. And we saw responses that were in immune excluded tumors, as well as non-responders. And so now we have this kind of interesting comparator that we can see that we can utilize to assess why we get responses in immune included tumors and why we get responses in immune excluded tumors. So if we focus first on the immune-included tumors, we wanted to see if there were ways that those cells were actually organizing themselves within the microenvironment that helped us to understand why those patients did better or worse in terms of their survival and response. And so what we did is we layered on our chromogenic staining with H&E. We also layered on our multiplex immunofluorescence staining, and we layered on our transcriptomic profiles to really see how these all were coming together to help us understand what was happening in the tumor tissue at baseline. What we found, we've looked at this data upside down and backwards to try to understand how these cells are really engaging with each other, and this is work that's been done by Gayatri on the team. And again, what we see is that there's no difference in immune-included tumors. There's no difference in the overall numbers of cells between responders and non-responders. But what we are appreciating now is that it's actually their location that matters. When we look at how the immune cells are clustering together between responders and non-responders, we can identify that in a high-grade responder, which is shown here at the top, when we look at where those immune cells are clustering together, they're actually within the tumor region. They look like they're directly interacting with the tumor, and they're forming different clusters in different communities, but specifically within that tumor region. Versus a high-grade non-responder, which is shown here at the bottom. I apologize, I don't think I have a laser pointer. Maybe I do. No, not a good one. On the bottom here on our high-grade non-responders, we still see plenty of immune cells, and we see them clustering in different ways, but they're actually not engaging with the tumor. They are stuck in the stroma. And so it looks like that is what is actually stratifying our patients that have response versus non-response is not necessarily the direct presence of the immune cells within the microenvironment, but actually who they're engaging with. You can see another example here where we're looking at different types of cytotoxic T cells, Tregs, and other types of TIL. Again, similar frequencies within responder and non-responder tissues, but in patients that have a better outcome, the immune system is already engaged with the tumor at baseline prior to therapy versus patients that did not have a good outcome where the immune cells are present, but they are very much excluded and stuck in the stromal compartment. So what about those patients, though, that don't actually have appreciable immune infiltrate at baseline? How are they responding to this immunotherapy combination? Well, one of the possibilities is the importance of IPI in this context, because we know ipilimumab can help to prime T cells in the tumor draining lymph node that can allow them to then come back into the tumor and engage in their activity. And so we wanted to see if we could identify any evidence to support a potential role of priming in this setting, and especially to help us again understand why patients without immune cells in the microenvironment at baseline do well. So to answer this question, we utilize the longitudinal assessment in the blood, where we're looking at immune activation states between baseline and cycle 2, week 9, looking at cytokines, looking at the immune cells in circulation, their function and activation changes, and then also looking at TCR sequencing to see if we can identify new TCRs that are coming up by cycle 2, week 9 in patients that do well. So what we can see when we look at the cytokine presence in circulation is that we have a strong evidence that the combination therapy is promoting immune mobilization. We see that there's a lot of chemokines that are coming up after therapy between baseline and cycle 2, week 9. You can see that in A. And when we stratify by response in C, and we look at what's coming up or coming down in patients that do well or do poorly, we see things like interferon gamma, we see trail, we see PD-1 coming up in circulation in responders. And we see this at cycle 2, week 9. Really at baseline, they all look pretty comparable to each other. And then we see other things in non-responders coming up like IL-8 that's associated with a lack of response. I know this is small, and I apologize for that. But when we look utilizing CyTOF to try to understand if there's differential function states of the cells in circulation associated with response, we actually see this very clearly. We see very specific populations of effector memory cells coming up at cycle 2, week 9, only in patients that do well versus patients that have stable disease of less than 6 months or patients that have progressive disease. And we can also see that this is true in both CD4 and CD8 positive T cells in circulation. We are getting immune activation of both. What we don't see is any difference in cytokine secretion. We don't see changes in polyfunctionality features that are associated with outcome. Instead, we are seeing more of this memory population that's coming up, but we're not capturing any changes in their cytokine production. So what about the potential for immune priming? If we're getting immune mobilization, we are seeing changes in memory states, and this is associated with outcome. Do we actually see any potential priming? And again, turning back to our TCR sequencing, this is work that we're doing in collaboration with Dr. Alex Rubin and Pei-Shin in his lab. And here we're looking at different metrics that we can assess when we look at the TCR repertoire. We can look at things like overall density of the cells in circulation. We can also look at how diverse they are, how clonal they are, if we have certain clones that are really coming up and changing, or if this is broader of a response. And then we can look at how those TCRs are shared using a Jacquard index or the prevalence of high TCRs that could be shared looking at a Morasita index. So when we look at cycle 2, week 9 in circulation, and we look at all the TCRs, you can see this kind of a map. This is all TCR overlap. We have only, unfortunately, one responder patient, but we do have 3 stable disease patients. When we look at all TCRs in circulation, either looking by the Jacquard index or the Morasita index, we don't see a real change related to outcome. Instead, what we can see is that all TCRs are still essentially shared at the high frequency clone level, but we don't have a very high Jacquard index. When we look at the tumor-specific TCR, so again, we have some cases where we could look at TCRs within the tumor, and if we restrict to those specific TCRs, we see the same thing. We see that the high-frequency clones are actually shared over time and by location, but we also see that there's quite a few of clones that are not shared over time or location. When we asked the question whether or not the T cells that were already present in the tumor could predict outcome, and we looked at progression-free survival here, assessing TCR richness, clonality, and density, and we're specifically looking at those TCRs that are shared between the tumor and in circulation, we don't see any association with outcome. But what's very exciting is that we do see an association with the cells that are in circulation in terms of their richness and density at cycle 2, week 9. So what that tells us is that we have essentially new TCRs that are coming up at cycle 2, week 9 that we're not seeing at baseline and we're not seeing in the tumor tissue. And this suggests to us that we might actually have evidence now of immunologic priming. which is supported again by that immune mobilization and activation that we see in circulation. Now, to definitively make sure, or to at least better classify these TCRs, we are in the process of removing any known viral specific TCRs that have been characterized and published on. We can actually remove those from our data set to then at least focus on what could be potentially the anti-tumor component. But it's very exciting to us to actually see then that we have this change. It's specific to cycle 2, week 9, and it supports the possibility that we might be engaging in a priming event. So in terms of what we've learned, this has been such an exciting collaboration for us. We've learned a lot here. We've assessed the PD-L1 and TMB, at least in cohort 23 and 52, does not correlate with response. We also see that other types of immune cells are very critical within the microenvironment at baseline in terms of association with outcome. B cell presence, lymphoid aggregates, as well as dendritic cells, and having that good antigen presentation populations there are very important in terms of responders versus non-responders. We also saw that grade actually was not associated with immune infiltration by T cells, and we were able to identify responses in very immunologically cold tumors versus those that had some moderately infiltrated cases. And there's quite a degree of heterogeneity in terms of the T cell populations that we can identify, but what's become very clear now is it's their location. In patients that do well, that are in immune included tumors, those T cells and those immune cells are really engaging with the tumor itself, versus the patients that have a worse outcome, those immune cells are really stuck in those stromal regions. When we look at the circulating response and trying to understand why patients that have a more immune excluded phenotype in their tumor tissue might be responding, we really see that we have these subsets of effector memory and effector cells that are really coming up at cycle 2, week 9. And we're getting very clear signs of immune mobilization using our cytokine and chemokine profiling. And this increased diversity and density of the TCR repertoire at cycle 2, week 9 in circulation really suggests that we might have some signs of immunologic priming, really highlighting the importance of this combination strategy in these rare diseases that have less of an immune infiltrate. The importance of priming as a possibility was pretty evident to us now in this combination. So in terms of where we're going, there's a lot of deeper dive that we want to take in terms of the genomics. As Dr. Chai mentioned, there's a lot of different features here that we need to be thinking about: copy number variation, HLA loss of heterozygosity, as well as mutations in specific pathways that can be related to immune activation states. And this analysis is currently underway. We would also like to better understand these T helper cells, because in this data set, we saw some, cytotoxic T cells, but we also see a lot of T helper cells that are not Tregs, and then working together with our colleagues within the DART leadership to put together our collaborative manuscript. So I just want to thank you all for your time, attention, and collaboration. It's been such an amazing journey, and we're so happy to work with you all through the CMAC. Happy to take any questions.
So happy to entertain questions, and I'm going to start because I have a few questions and a few comments. First of all, this has been a really fantastic collaboration, and I really appreciate you and Dr. Chai, what you've done. And it's always great to get on a Zoom with you because you bring so much passion to this. We've repeatedly found that PD-L1 doesn't correlate with outcome until you get to really high PD-L1 levels. And so my first question is, have you looked at dichotomizing it at a much higher level, like 50% or something like that?
Unfortunately, in this specific cohort, we don't ever hit that.
We don't see it.
Yeah, we had to set our threshold at 1%.
And then, and with 1%,
Yes.
It's really hard to publish it, by the way.
Yeah.
We had we might have been rejected by 10 journals before we got it published. So if you say you don't see it in the literature, it's because nobody wants to hear it. The other question is the same question for TMB.
Yes.
I mentioned before with Dr. Chai that the TMB cutoff at 10, which the FDA put forward, I think, to give patients the opportunity to get the drug, we found that between 10 and 16, which is our publication, but really probably between 10 and 20, there's not a lot of responses, and it really dilutes the high TMB. But when you get to higher cutoffs like 16 or 20, we see a pretty pronounced signal. So is there enough patients to look at that, and have you looked at that in this cohort?
In this cohort, we had 5 patients that responded where we were able to assess TMB, where we had the normal and the tumor. We only have 1 that's really above 16. The other 4 are all less.
So you don't have a very large cohort
No.
to be able to ascertain
That-
one way or the other.
Exactly. That would be really a key question to ask with the rare tumor TCGA.
Okay. Are there any other questions from anybody else?
Yeah, excellent work.
Thank you.
So one of the things that we see in clinical practice is that with nivolumab and ipilimumab, still responses tend to be small, survival still tends to be short. So you mentioned that there's a lot of factors that potentially, basically immune excluded or immune included that potentially predict response. I was just thinking, do you have any data in terms of for patients who do respond but then stop responding? Can you predict any factors that might be contributing to that?
That's a great question. Not easily with cohorts of this size, unfortunately. That would be something, though, that would really be important to assess across cohorts in the future. But given the patient numbers here, we can't really adequately go that direction. But it's a key point and something to very much look into in a bigger study.
I'm going to let you ask the question, but really quick because we're now running behind.
Just had a quick question on any other checkpoints like TIMLAG, Vista, anything, a quick word on that?
Sure. Well, yeah. In terms of the data from this cohort, we did not see any association with other checkpoints and outcome. Really, the strongest signature was the B cell presence was the most important. And our multiplex data wasn't designed in a way to look at all those checkpoints on the TIL. In circulation, we see that PD-1 expression is important on the circulating effector memory cells. We didn't see an effect looking at other types of checkpoints that were present, but that is in circulation. And really, you need to think about that in the TME as well. So we don't have a clear answer there. It's a great question.
Okay, thank you so much. And again, great. And our next speaker is Dr. Manmeet Ahluwalia, and I've gotten much better at the pronunciation. I think I did get it right now. And he's the chair of the CNS working group and is going to give us that update. And then as he walks up, I just want to there's some comments that I've ignored, but I have to say one of them because it's very clever, and it's for Dr. Chen. Adrian Victor, under my skin that I see Merkel cell carcinoma fairly regularly, sometimes without a skin primary. Is that included in your newer endocrine cohort? That question's worded so cleverly, I have to ask it.
Yeah, no, great question. Unfortunately, no, not for this trial, just because Merkel cell is a little bit of a different entity. But I know there are some national trials that are being planned for that. So,
okay, thank you, Dr. Ahluwalia.
Thank you so much, Dr. Kazrak, and a fantastic presentation as always by Dr. Macker. So I'm going to give you the CNS working group update. First is this phase 3 trial of post-surgical single fraction radiosurgery compared with fractionated SRS for resected metastatic brain disease. PI is Paul Brown from Alliance. It's an Alliance trial that we are helping out. So basically, we all know for patients with brain metastases, when you actually just do surgery, if you don't do any follow-up, either any form of radiation, those patients don't do well. Traditionally, single fraction radiosurgery was considered as the go-to, was found to be, probably better tolerated and compared to whole brain radiation. But more recently, there's been a lot of data coming out in favor of multifraction SRS, that is basically giving the radiation, but over a course of 3 fractions or 5 fractions, and people have different aspects of it. So this was the schema: patients with resected brain mets for more than 2 centimeters. Typically, if patients have a brain met that is less than 2 centimeters, a lot of people just do radiosurgery unless you actually need the tissue to get a tissue diagnosis. That's pretty much become a standard of care at most places. So after the surgery, people are going to get stratified, and they were randomized to stereotactic radiosurgery to the bed. So this is a resection bed where the surgeon has removed the tumor. Often people will have more than one brain metastasis, so you can still do radiosurgery to the unresected mets. And then there's a fractionated radiosurgery. So this trial actually has fully enrolled now. And we don't have an idea on the date of presentation, but there is an interest in fractionated radiosurgery, which is actually nowadays the go-to question. The next trial that SWOG is actually participating is this time has been headed by NRG. This is the BN007. The previous trial was led by Alliance. Now, this is trying to again look at the question of stereotactic radiosurgery. So for people who don't treat brain metastases on daily basis, stereotactic radiosurgery really has become now the foundation of treating these patients. But what we find out is when you give people stereotactic radiosurgeries, there is a group of patients who actually progress very quickly, which is probably more related to the innate biology of the disease, like triple negative breast cancer or some forms of wild type lung cancer. And so this concept have come up, which is called brain mets velocity. And what it really means is how many new brain metastases will come after initial radiosurgery. And the question is are those people the right candidates then to do radiosurgery, or those would be the people who you would consider to do hippocampal avoidant whole brain radiation. So whole brain radiation used to be used to treat patients with brain metastases like 20, 30 years back. More recently, we have started using hippocampal avoidance to preserve neurocognition, which is one of the biggest challenges when we do whole brain radiation. And then also pharmacologically, we have shown that memantine can actually also help in preserving the neurocognition. So this trial is looking at patients who have a high brain mets velocity and depict an arbitrary number of 4, trial led by Vinay Gandhi and Michael Chang after first or second distant relapse. And then again, patients are being stratified to either get SRS alone or SRS plus hippocampal avoidant whole brain radiation at 30 grays, which is typically what we do along with memantine. This trial actually is struggling for enrollment in all the cooperative groups. We've struggled to enroll it here too, just interacting with Dr. Tony Wang, who's our radiation lead. There's a good chance we may not know the answer. The reason for that is most people now just like to do radiosurgery. There's a lot of data in favor of radiosurgery, and the equipments have improved tremendously that actually you can go and do anywhere from 3 to 10 brain mets, even more on a single day. So next, moving on to NRG BN007. Now, this is obviously, we heard multiple great presentations on DART. So this was the DART equivalent in unmethylated MGMT. So this was a randomized phase 2/3 open label study of ipilimumab and nivolumab, comparing it to temozolomide in newly diagnosed unmethylated patients. So frame of reference, temozolomide is an alkylating chemotherapy. We use it. In glioblastoma, this has shown to have survival benefit. But what we know is that in unmethylated patients, temozolomide only gives us 21 days of benefit. Okay, so we really give people 6 weeks of chemotherapy with radiation, followed by 6 monthly cycles roughly. So 9 months of chemo essentially for a 21-day benefit. So the question was, can we skip temozolomide and treat patients with just ipi-nivo? So this is the DART version, right? So essentially the trial actually was presented. I couldn't get the slides, but I'll give you the take home points. Unfortunately, ipi-nivo did not prolong progression-free survival or overall survival. So this has been the story of immunotherapy in glioblastoma so far. Checkmate 143 study was in nivolumab compared to bevacizumab in recurrent glioblastoma, no survival benefit. Nivolumab was compared to temozolomide and radiation in methylated patients. That was the Checkmate 548. No progression-free survival benefit, no overall survival benefit. Then we wanted to ask the question, is dual immunotherapy any better? And this now, the trial basically showcases that there's no progression-free survival benefit, no overall survival benefit. In fact, the overall survival was 12.8 months for temozolomide arm and 13.1 months for ipilimumab nivolumab arm. That was exactly the survival in 2005 when temozolomide was presented. So unfortunately, we haven't moved the needle for these patients, and we need to do better. Next, moving on, this is where we think there is a little bit more hope, because here now they're looking at, again, the DART therapy, and we tried to, see if we could open an arm in the DART trial for these patients, because this is where we think there might be some value. So these are somatically hypermutated recurrent glioblastoma patients, but basically Alliance stumped us. So they actually had a full trial proposal, so we couldn't get the approval. And they were going at it around the same time. They might have been ahead of us by a month or two. So here the trial schema is patients who have glioblastoma, who actually are undergoing, Foundation 1 testing, and they have here the high TMB is defined more than 20 mutations per megabase pair, and they will get the Nivo-Ipi, and if they have more than one response in first 18 patients, it will then be expanded to 14 additional patients. What I will say so far, though, is that use of Nivo alone has not really changed the landscape. When we have treated some of these patients anecdotally, there was a 10-patient cohort reported by the Dana-Farber group and Gustavo Ruvi in a collaboration. There was no change with these. Actually, traditionally, from a disease biology point of view, the hypermutated patients actually do worse. But then there are different thoughts of why that's there. So we have two proposals going through our group. One is a proposal led by Dr. Tony Wang. Now it's again looking at a different dual immune checkpoint blockade, again in unmethylated patients, building on the same concept, right? The temozolomide only gives 21 days benefit in this patient population. So this is a study of itolizumab along with tocilizumab with radiation in patients with newly diagnosed unmethylated MGMT. So instead of the Ipi-Nivo now, we're going to try atezo-toci. Basically, there is work from preclinical work that in orthotopic glioblastoma murine models, there is a benefit of combining these two. In fact, this has led to a study out of NRG where they're looking at it in recurrent setting. But just to give you a perspective, we are focusing more in upfront setting, because in recurrent glioblastoma till date, no therapy has shown even 1 day of survival benefit. So that's why our focus has been more in upfront trials. So we do know that anti-IL-6 therapy will reduce the CD68 myeloid cells infiltration and increase the CD8 toxic C cells infiltration. This was again then looked in mice models, and here you can see there was a benefit clearly in the green curve with the combo. So building on this, we have a phase 2 concept, newly diagnosed patients again, radiation, which is the standard of care. We are skipping temozolomide. Instead, we are giving atezo-toci along with radiation and then with maintenance. And it's again, a small trial, because what we feel is given the Ipi-Nivo lack of success, it will be difficult to sell the brain malignancy steering committee on a randomized phase 2-3 study. So we will want to look at, what will be the preliminary efficacy. And I think our group is, probably well situated to do it, because we have a sister study to it, which is the TRC-102 and temozolomide in patients with newly diagnosed glioblastoma. And here, basically, when we give temozolomide now, this is in methylated patients. Now it's a different story. What we know in methylated patients is when we give them temozolomide, they actually form 6-methylguanine and 7-methylguanine and 3-methyladenine adducts. Out of this, the 6-methylguanine DNA adduct is actually repaired by MGMT. So patients who have MGMT methylated tumors, they actually get durable benefit with temozolomide. The 21-day benefit in unmethylated patient is more like a 6 to 7 month benefit in these patients. And that's what drove the overall curve, which led to the approval of temozolomide with a 2.5 month benefit overall. But what we do know is that base excision repair pathway then clears out the 7-methylguanine and 3-methyladenine adducts. And so building on this, Dr. Stan Gerson, who was the comprehensive Case Western director, actually, this drug came out of his lab called TRC-102, which is a base excision inhibitor that binds to the apurinic sites created through the action of MPG, that basically stands for N-methylpurine DNA glycosylase. Sorry, a mouthful. That there was work done by Andy Sloan, who's a neurosurgeon at Case Western, showing that in orthotopic xenograft models, a combination of TRC-102 and temozolomide actually surgery provided benefit. So we took this through an Adult Brain Tumor Consortium, which was supported by CTEP. We did a phase 2 trial, but the CTEP only allowed us to do it in recurrence. And so this was patients who had progressed on temozolomide and radiation. They were given temozolomide and TRC 102 at 150 milligrams flat dose, which was showcased by a trial done by Alice Chan at CTEP to be a safe dose. And what we found out was that it was a 2-stage design study, 19 patients in first stage, 32 patients in stage 2. They had set up a very high bar for us, a response rate of 30. Okay, now just to give you a frame of reference, in recurrent glioblastoma, I think I told you there is not even a single therapy that has shown even a single day survival benefit. The response rates are pretty much 4 to 5%. So unfortunately, this trial failed to meet its primary endpoint. A median progression-free survival was 2 months. Median overall survival was 11 months. Now, all the trials that have been done in recurrent glioblastoma, median progression-free survival is 2 months. You know why? Because that's the time to next MRI. So that's the story of our lives, and unfortunately of the patients who have this disease. So we need to do better. Progression-free survival at 6 months was 10.5%. Again, very typical what we have seen with others. But 2 of these patients, actually, I had treated myself at Cleveland Clinic, and I saw they actually got durable benefit. One of them had a progression-free survival of around 18 months. One of them had a progression-free survival of around 30 months. So we luckily had another IRB, and this actually speaks to the value of translational research and this aspect of, learning from every patient that you treated. So what we did was we wanted to compare this to historical cohorts. And what we found out was that out of the 19 patients, although the median progression-free survival or overall survival was not different than the historical cohorts, but in the MGMT methylated patients, there was some improvement in the median overall survival, which is 30 months, okay, which looks interesting. Again, 5 patients, hypotheses generating very large confidence intervals, but some aspect. So what we did was we had an IRB, and so we sent our tissue for transcriptome analysis to TGen with Mike Beren's lab. And so he did whole exome sequencing and transcriptome analysis. And what we found out was that 2 patients who did better actually had a DNA damage response pathway signature. And there was 1 patient who just progressed after 6 cycles. So it was actually 175 days. So he didn't meet the 180-day criteria, but his overall survival was around 30 months, and he had a borderline signature. So even with 7 patients, we have a hypothesis here, which we want to take to a trial here. And so what we have found out was that the OS in the MGMT promoter methylation was 30 months, which is very promising. So we will do the trial in methylated MGMT patients, building on that hypothesis, but we are going to validate this signature in prospective setting. And this signature exists when we have looked at the TCGA in around 10% of the patients. So then that holds true because 2 of our 19 patients, which is roughly 10%, had the signature. So our hope is, but if we run a trial of only MGMT methylated patients, which is around 35% of of the entire GBM, then it will become 1/3 of those patients. So at least we'll have a larger cohort. And so we're going to do the study here. There is a continued interest. We just submitted a manuscript for publication. We had a good, reasonable review in the Cell Reports Medicine. We hope it'll get accepted there. The CER is in favor of running the trial through CTEP. CTEP actually, at least on initial interaction, is very supportive. So our plan is to run these 2 trials through our CNS working group. There continues to be interest in Roche to support the first study as well, despite the IPI-NIVO result. We still don't have a lot of information from the recurrent GBM trial that is going through NRG, but unfortunately, there's almost nothing else that is working in glioblastoma. So we need to do better for our patients, but that's our state of affairs.
Okay, well, thank you. Go ahead and ask a question, and then I have a question. And
Thank you. A really nice presentation, Dr. Aluwala. My question really is, if we know that the methylated patients are the ones who do the best with temozolomide, I think there's some evidence to suggest that there's a hypermutator phenotype that tends to happen with temozolomide use long-term. So does it make sense to maybe target those patients with immunotherapy, maybe in combination temozolomide rather than unmethylated patients?
No, so that's a great question. Actually, we did, with the nivolumab Checkmate 548 study was only looking at MGMT methylated patients. It was a randomized trial of radiation plus temozolomide plus nivolumab compared to radiation and temozolomide, which is the standard of care. There was no progression-free survival, no overall survival. There's actually a little bit of story developing that these hypermutator types that actually develops post-alkylating therapy is not like your regular hypermethylated tumor. So the germline patients, actually, we're getting fantastic responses. There's work from Eric Buffet's group in University of Toronto, where they had actually a beautiful JCO paper where patients had like 33,000, just enormous amount of hypermutator phenotype, getting phenomenal benefit from Nivo, shrinking tumors, like just melting away. But what we have found out is that most probably these are more subclonal mutations rather, and they're not, although they're leading to high TMB, but it's not really something that will respond to. But hopefully the Alliance trial that we are supporting will answer that question once and for all with the dual immune checkpoint block.
Yeah, so I have one comment, and then if we could get Dana Sparks to come up in the meantime. One of the resistance factors for immunotherapy or even hyperprogression is EGFR, which is very frequent in GBM. So has anybody checked, is EGFR, I don't know exactly, but I'm imagining EGFR overexpression or abnormality is 50 to 60% or more. And so is that the issue, or that could be the issue why these patients aren't responding?
That's actually a great thought. No one has looked into it, but maybe we can actually interrogate, because most places are getting EGFR with because most patients at most places are undergoing NGS testing. Because certainly no one has explored it. And you're right. I mean, I think it's like 40 to 50% expression, at least overexpression. But no one has looked at it, and I don't think that has been looked at.
So I think it's a question very much worth looking at. That was a great presentation, very difficult area, but ripe for
But that EGFR might be a great story, because on a different trial, we are finding a drug that actually works in those patients. So maybe those EGFR patients are very different than our GBM patients. We've always fixated more on MGMT just because it's a predictive marker as well as a prognostic marker. And we've always looked at alkylating therapies, but in era of targeted and therapies and immunotherapies, we will probably want to relook how we classify our tumors. So thank you for that suggestion.
Thank you. So Dana Sparks is going to talk to us about Combo Match, and she's the Director of Operations for SWOG. And thank you very much for doing that.
And turn it back on. Sure. So I'm going to provide a little update on Combo Match, plus solicit ideas for future studies for Combo Match. Some of you may know that this study was activated earlier this year. It takes a long time to set up a platform study. And of the three new platform studies that are going to be run through the NCI, Combo Match is the first one. So there was that steep climb up the hill to set up the platform for Combo Match, but that's been done. And you have to have a certain number of sub-studies in order to be able to adequately set up the platform. So we had one SWOG study in the first generation of Combo Match sub-studies. Dr. Riva Basho is the PI for that study. And I borrowed some slides from Dr. Jim Ford at ECOG just to give you a taste of a summary of Combo Match. But also the big announcement here is that we've chosen to move the operational piece of Combo Match under the Early Therapeutics and Rare Tumors Committee, because it's a good fit. And it also helps to build all of the structures that help a committee run well, help a study run well in a committee. We didn't have that in place within SWOG for Combo Match, and now we do. So the idea of Combo Match obviously is to create combinations using a targeted agent. The extent of the benefit is decided on as part of the statistical plan for each sub-study individually. And Combo Match is intended that the overall design of the study is, the hope is that at least 30% of the cohorts will meet their primary endpoint. So that's the idea of the structure of Combo Match. And then the intent there is that we want to have this precision medicine initiative that relies on preclinical evidence that generates studies that can be tested that we think would be likely to meet their clinical efficacy endpoint. There's a whole set of requirements for combo match studies. I won't read through these. The slides will be available if you're interested in proposing a study for combo match. These are the basic requirements. I think that one of the things that's important is that at least one of the cohorts in each individual sub-study for combo match must be histology agnostic. So that's one of the reasons why fitting into the Early Therapeutics and Rare Tumors Committee makes a lot of sense. And there is the centralized standard of care genomic sequencing that's going to be used to identify patients and then match them to the individual studies. This basically outlines how the registration protocol works in defining patient populations that would then go on to the individual treatment sub-studies. And then the overall registration trial eligibility, so this is kind of funnels down to the individual sub-studies, is that this is intended for patients with locally advanced or metastatic solid tumors who have measurable disease, and they must have progressed on at least one line of standard systemic therapy or have a disease where there is no standard. So basic information here. There are cohorts that are built specifically for younger patients. So SWOG is also participating in combo match. The first wave of treatment trials. So the ECOG is running the screening part. And so EAY 191 is the screening protocol number. And then for each of the treatment trials, they have a designation of the group that's running that trial. So N is for NRG, S is for SWOG, E is for ECOG. So the trials that started out in the first wave of activation were 2 NRG studies, one looking at binimetinib and fulvestrant, one looking at olaparib and selumetinib, and then the SWOG study that's looking at ipatasertib and Taxol. And then you see the relative molecular eligibility. So the SWOG protocol is in that PK3CA AKT cohort. There are several future studies that are already planned. These studies were actually intended or hoped to be in the first wave of activations, but for one reason or another kind of fell behind, but they're still in the pipeline and will be activated. But now ECOG has asked all of the groups to ask our investigators to think about studies that will be appropriate for the next wave of sub-studies in combo match. So I wanted to make sure that I supplied you with general information about the study. So the URLs here and the email go centrally to the NCI and ECOG study chairs. But within SWOG, it's important to point out that we thought it was really important, and ECOG did as well, that all of the processes for review of these studies, because they don't fall under a specific NCI steering committee, that they work in parallel with each other. So the NCI and this whole process for selecting which studies move forward, which combinations might work, all of these subcommittees have participants from the NCI on the subcommittee, so that by the time the concept is submitted formally to the NCI for review, it's actually already been fully vetted by the NCI. So since ECOG built this pretty elegant system, although it took a while to get there, we didn't want to add anything on the front of it. So for SWOG sub-studies that are moving through combo match, we wanted to make it very simple. So we have a 2-person review. Initially, Dr. Lyman and Dr. Merrick Bernstam are doing the initial review. They make sure it's eligible for a combo match, and then we run it through Dr. Kurzrock and Dr. Ryan and the statistical center, and then we send it on to the combo match system. So no central executive review from SWOG. So we're hoping that this will simplify the process for everyone. Chrissy Laubach, who is here, is our protocol project manager for combo match. All of the sub-studies in combo match are individually run by the group that proposed them. So ECOG runs the central structure, but each of the sub-studies is run separately within the individual groups. So we wanted to make sure that we had, and the NCI did too, we have additional resources supporting the combo match system that are separate from the traditional committee resources. So we aren't cannibalizing from the early therapeutics committee to support combo match. So Chrissy is the central contact person administratively. Dr. Lyman and Dr. Merrick Bernstam are the scientific leads. And I think that's all I have. I think Dr. Basho is on the line. I don't know if she has anything she would want to add. She's been through the process. And we do hope that now this first wave is done, it will get easier. The building of the platform is the most difficult piece. And so as we move forward, moving new studies through the combo match system, I think will become much easier over time. That's all I have.
Well, thank you. I think that's a really exciting initiative. And I would ask if you could send me and Dr. Young Chai the slides, and we may have you both, you and Dr. Basho, back quite frequently at our committee meeting to update us. But we'll distribute to the slides if it's okay with you to the rest of the committee.
Absolutely,
But
yeah.
if you-
I think so the sessions will be recorded and will be available on the SWOG website, so people can access them that way, but we also can separately
just
provide the
email
slides.
me the
Yeah.
slides and Dr. Yochai will get them.
Thanks, Dana.
Chris?
That was very informative. What's the mechanism for us staying on top of combo match? Like when they're soliciting for, I mean, do we have to have some representation on?
So Dr. Merrick Bernstam and Lyman are on their steering committees and on their working group, so that they can kind of start that process moving forward. But the ECOG had stopped accepting any new proposals for a while to concentrate on getting the study up and running. And now there's 39 accruals to the screening step. So at least it's started that process. And so now they're opening it back up for new proposals. Everyone should have last week received kind of a blast from the SWOG central mailbox soliciting for new proposals. So this is kind of starting from scratch again.
And we'll work with Chrissy on.
Yeah, I think Chris has a very important question there. I think we feel like we're not on top of it.
Yeah.
And so we don't want to be an extra step or block anything. If you know me, that's not my way of working. But we'd like to be on top of it. So I don't know if there's some way to have us or somebody from the committee as a liaison to this steering committee.
I think that would be a really good idea. I was actually going to suggest that, but I wasn't sure if you were prepared to assign someone to that.
No,
but I think we can do
absolutely.
that,
I
yeah.
don't think that I don't think it's going to be me. My bandwidth is, pretty full, but I think that there's probably quite a few people in the committee that we are interested. And I would feel better if we had somebody.
And I know also Dr. Lyman and Dr. Merrick Bernstam are very busy. And so having somebody to help move the process through, it would be really helpful. I
Yeah,
think.
so again, if you could suggest that,
Mhm.
that we have some representation on that steering committee,
Mhm.
either as a member or as a liaison.
Mhm.
Again, just so that we can keep updated.
Definitely.
Just 2 points of clarification. So for one, on the criteria for combo match cohorts, it stated that at least one has to be disease agnostic. Is that one of each group at a time? Just
No,
confused.
it within a study, within a sub-study, it has to have at least a cohort that is disease agnostic.
Because like
so-
on the ones you showed, there
Yeah.
was like ER positive breast cancer.
Yeah, so while they may have a focus on a disease, there's also an agnostic cohort that has the same mutation.
Okay,
So the
okay.
if you look at the individual designs, there's multiple cohorts within each sub-study.
Got it. And then the other thing is most of the drugs come out of the CTEP compendium or are these? Yeah,
So what CTEP has committed to is that they have created a rapid contracting process. And so if the drug is not already existing in their compendium, they will immediately get on board with contracting with the company. But part of that whole review process is getting the commitment from the company. So that's part of what's built into that.
so final that builds off that, you said phase 1 will be required if there's not clinical demonstration about safety. Does
Right.
that mean a phase 1 run it?
Outside of
Got
the
it. So
combo match.
ATCTN,
Yeah.
got it. Okay, then. Yeah.
Okay. Any other questions? Great.
Other questions? Okay, well, on that note, I think we will close out. Thank you. That was really very informative. I want to remind everybody that we have a dinner at 6:00 today, and I don't actually, it's someplace in the hotel. I still have to figure that out. But I think there's still some space for some extra people. We didn't reach our max. So if some people here want to have dinner, and there'll be some other presentations that are relevant to early therapeutics and rare cancers, please feel welcome to join us at that dinner. And if you email me, I might be able to tell you where it is. Anyway, thank you for your participation, and have a good rest of the meeting.